So once again, we're pleased to be bringing you this IHSPR policy round focused on performance anxiety. How do we advance performance measurement in Canada? This webinar features research that was presented at UBC's 2014 Centre for Health Services and Policy Research Conference on performance measurement, which was co-sponsored by CIHR's Institute of Health Services and Policy Research and CIHR's Institute of Population and Public Health. We have three presenters today that I'll be introducing shortly, Sabrina Wong, Victoria Lee, and Jeannie Haggerty. And they were all actively involved in the conference, and so they'll be sharing with you some of the key research that was discussed at the event with us today. I also wanted to acknowledge that we have quite a few people on the line, as I mentioned. Quite a few had registered, and I think we're now up to over 120 people. It looks like we've got people online from all across Canada, and a number of representatives from different healthcare stakeholder groups, including provincial territorial authorities, departments of health, health research organizations, and universities. I also saw a few of the members or tripartite leads from the CIHR SPOR network in primary and integrated healthcare and innovation. So welcome to all of you, and thanks again for joining. So the learning objectives for today's webinar, I'll just run through them quickly. We want to understand the science of performance measurement within the primary healthcare context, learn about best practices for reporting on performance measurement, demonstrate the usefulness of comprehensive primary healthcare performance measurement as a foundation to inform innovation in delivery and organization of the Canadian primary healthcare system. And finally, to explore performance measurement best practices and questions. So I'll introduce the speakers, and some of what will be talked about today includes what is performance measurement, conceptual framework, the science and art of performance measurement, reporting of performance measurement, and then we'll have some discussion and question and answers through the chat mechanism. And I'll just note that once the webinar closes, a survey will pop up on your screen, and we would appreciate if you would take a couple of minutes just to respond to that and provide feedback on today's session. So without further ado, I'll just introduce the three speakers. First, we have Dr. Sabrina Wong. She is appointed at the University of British Columbia in the School of Nursing and the Center for Health Services and Policy Research. Her research focuses on primary health care, specifically how structures and processes can enhance the delivery and organization of health services. Her current projects focus on improving the science and reporting of performance measurement in primary health care and comparative policy analysis in this area. Our second speaker will be Jeannie Haggerty. Dr. Haggerty holds the McGill Research Chair in Family and Community Medicine Research based at the St. Mary's Hospital Center. She is a health services researcher whose domain of research is the factors related to accessibility and quality of primary care in Canada and in developing countries. In recent years, she has focused on the development and validation of measures of patient and provider experience in healthcare. And our third speaker is Victoria Lee, and Dr. Lee is a family medicine and public health and preventative medicine physician. She has worked in collaboration with national and international organizations such as the United Nations Environmental Program and the World Bank in areas of eco-health, comparative health systems, and health policy. Her research interests include determinants of health and health equity, community-based primary health care, health financing and economics, and comparative health systems. So these are the three presenters we have today, and I am now going to turn things over to Sabrina Wong to kick off today's presentation and talk about a little bit about the partnerships involved.
Great, thanks a lot. So I just first of all want to acknowledge all the different people and organizations that have been part of this. So now, of course, I'm trying to advance the slide, and I can't remember how to do that. Okay, let me see. Oh, there we go. Okay, so these are just some of the different organizations that are represented talking with us today, and there's many more. And so that is good. So the next slide is, the next section really is looking at what exactly do we mean by performance measurement. And this is being brought up and was talked about at the conference that we had. And I thought this was really well done by one of our colleagues who was at the conference, Dr. Jean-Frédéric Levesque, and he is at the Bureau of Health Information in New South Wales. And he recently released a report where I thought it was really well explained about what performance measurement is. He talks about how people are actors, perform on stage, athletes perform in competitions, and surgeons perform in operating theaters, and that performance really is about action, and that action can be measured, and measuring what matters requires a systematic approach in capturing how care is delivered, reflecting the performance of healthcare workers, organizations, and systems. So performance measurement can be used for a variety of purposes, generally aimed at enabling actors to make better decisions. And multiple jurisdictions across Canada have now implemented and expanded their use of performance measurement and reporting. And we see many places wanting to do that. And performance measurement should be done through the perspectives of different people, right? So organizations, providers, patients, and this is to try to ensure a comprehensive approach. So what are some of the goals of performance measurement? Here I've listed them here for you. You know, some of the goals of any kind of measuring of action would be to provide evidence of achievement on current strategic priorities and overall performance, to try to inform and catalyze quality improvement at the individual and practice level. And oftentimes we talk about performance measurement sort of more at a jurisdictional level versus quality improvement, which could be at an individual or practice level. And then the third goal of performance measurement is really to provide accountability for delivery of healthcare services. So this is really aimed at government and those who are providing services. They want to have accountability to their shareholders. Just as investors put out reports to their shareholders, so do governments, et cetera, that are delivering healthcare services. They want to also be accountable to their taxpayers and also to the public as well. So particularly in British Columbia and also Canada at large, we are in need of a robust performance measurement system. I don't think that we've seen such a system in Canada. It's probably the most developed for hospital systems, and probably there needs to be more work that's done, particularly in the area we know of primary health care, and also in, both primary care and also probably in public health, and you'll be hearing more about this in a bit. So here are some fundamental questions that we can start to ask ourselves when we're thinking about performance measurement. And these questions really bring to bear the light on the fact that context and the importance of developing measures about practices are aimed at meeting the needs of people with multiple health and social needs. And we need to improve our capacity to define what is needed to measure performance and to develop measures that move beyond single measure indicators to address challenges around comorbidity, chronic disease, and end-of-life care, as well as the multiple different contexts in which we live. And these questions help us begin thinking about the kinds of measures we need to examine and prompts us to start thinking about a conceptual framework by which to organize and place concepts important to the specific practice or sector. So that brings us to sort of the next section, and this is really a little bit thinking about the importance of conceptual frameworks. And as you all know, it becomes extremely overwhelming to look at the multitudes of indicators as well as measures and items, and it's very easy to get indicatoritis, as they call it. So given the complexity of performance in healthcare with its multiple decisions and interactions, and a mix of short and long-term time horizons, any meaningful assessment requires a conceptual framework to guide indicator selection, implementation, and interpretation. And again, some of this work, you know, there's been a lot of work actually in Canada as well as across the country looking at different conceptual frameworks. And again, our colleague, Dr. Jean-Frédéric Levesque, in the Bureau of Health Information lays it out quite nicely to talk about that there's 3 different approaches to performance measurement frameworks. One is goal achievement, so specifically to measure progress and focusing on targets and specific indicators. Another one is logic models, which focuses on the logical links between inputs, outputs, and outcomes, and attempts to attribute performance based on the various inputs and who is doing what and how much they are doing. And finally, another approach is to look at functional models, which is specifically focused on roles and mandates and striking a balance between internal and external functions. And I know there's some people on the line from the Canadian Institute for Health Information, and I thought I would share this one with you. It is clearly a logic-based model here, and this is the one that the Canadian Institute for Health Information has put out in terms of looking at health system performance. And so this is one that's fairly broad and general as to what our system ought to be able to achieve in terms of equity and outcomes. So the target of performance can be quite different depending on the conceptual model and where there are lines of responsibility. So for example, in Quebec, their outcomes might be someone else's processes. And as you can see here, this one is a logic model that does try to show links between inputs, outputs, and outcomes. And you can also see in this framework that there is a nod to the different kinds of contexts which might influence health system performance. So that would be economic context, demographic context, and political context. Performance measurement is demanding methodologically as well as its intent in terms of its need for data collection, and it can become a means in and of itself. For most people, however, it is both the performance measurement and reporting that matters. And that's why this conference was both about trying to improve the science of performance measurement as well as its reporting on. This particular framework reminds us that there needs to be support in performance uptake and application in order to actually achieve the health system outcomes. I can't remember how to use this little highlighter thing, but certainly in this area here, you would definitely want to be thinking about the reporting of it, right? So it's not just can we collect the data and build the information system, it's really about how can we be reporting on it. So what I'm going to do is I'm going to hand this now over to my colleague, Dr. Victoria Lee, and she's going to talk about some examples of performance measurement frameworks in population and public health.
Thank you, Sabrina. So Sabrina mentioned that we are in need of a robust performance measurement system to identify how and whether in our healthcare system is improving and how we're benchmarking relative to other systems. And there's been quite a bit of work that's been done in that setting, specific, I think, to acute settings. And then in terms of broader community-based systems as well as population public health, performance measurement and quality improvement are areas of significant interest, especially in the environment of increased need for accountability and also to demonstrate value for resource allocation and investment, and to, of course, improve the overall system performance. And as Sabrina mentioned, I'll provide some examples, but I would like to discuss challenges that we encounter in population public health practice and policy, and I think those challenges are not necessarily isolated in population public health field, but shared across health systems. And I'll do that by using some of the examples of performance measurement in BC. So in terms of the performance management system, there are 4 key elements of interest in public health. Firstly, selecting indicators, goals, and targets for performance standards, and secondly, performance measurements, so refining those indicators, defining measures, and developing data systems and collecting data, and then reporting of progress after the analyses and communicating those internally and externally, and also implementing quality improvement process that Sabrina mentioned that could be at individual level or at practice level to use data for decisions, again, to improve policies, programs, and outcomes. And this could also be used as a system performance as well as to create a learning organization and to manage changes. We often talk about the fact that what gets measured gets done. The challenge in population public health is that we do not always know what is important to measure, especially in the context of complex systems and complex adaptive systems. We are familiar with the elements that I've described in the performance management that are traditionally conceptualized as linear, one-dimensional, or sequential. However, issues in population public health are often relational, interlinked, complex, and multidimensional. Unfortunately, I did not include the slide that I had for the conference in BC, which was one of Foresight's conceptual model on the obesity system in the presentation. But I'm sure that a lot of you are familiar with that conceptual model, as well as the picture that depicts the tangled loops and connections of 108 causal variables. That conceptual model illustrates the extent of intricately interlinked variables that we often deal with in population public health, and the challenges related to selecting indicators that can represent the whole and complex system. It is important to, of course, balance the need to have a concise and reportable performance measurement system, but that need has to be balanced with the need to ensure that we do not have unintended and potentially negative consequences from the overall systems perspective. And again, I think this is the case in population public health field, but also within health systems realm as well. What we find in reality is that what gets reported, what we are actually required to report, is what often gets measured, and those are constrained by other issues such as capacity and access to data as well. So this is a graphic representation of core functions framework in BC. As a part of public health renewal in 2005, the Ministry of Health Services, back then that's what the Ministry of Health was called, in BC, developed core functions framework to strengthen public health and improve population in BC. The core public health functions framework defined and described the public health activities for a comprehensive public health system, and one of those core functions is actually provision of core public health programs. As you can see in the diagram, it describes the core programs in the areas of health improvement, disease, injury, disability prevention, environmental health, as well as health emergency management. Also specifies public health strategies such as health protection, health promotion, prevention interventions, and health assessment and disease surveillance. The framework for core functions in public health defines the system capacity requirements as well for success, such as health information systems, quality management, to ensure that populations of concern and of high priority are also addressed through using inequalities lenses. So with the core functions framework, the health authorities and the ministry started to undertake quite a comprehensive systematic approach to performance measurement and management under the guidance of that framework. From 2006 onwards. There were 21 core public health programs that were identified, and with individual programs we went through and we started to go through comprehensive review of principles, concepts, identification of goals and objectives, review of evidence, best practices, determination of appropriate indicators, benchmarks, and performance targets through performance improvement plans, as well as identification of capacity and support requirements. There were model core program papers that were created for the core public health programs as well. And according to the core functions framework, the vision was to implement a performance improvement process over several years to benefit and contribute to public health infrastructure, health information and surveillance systems, workforce competence assessment and development, and research and evaluation, of course, at the regional level as well as provincial and national. So that takes me to another challenge that we often face in population public health is one of changing context. As you are very familiar with political transitions, we also have transitions in what's required. So as we move forward with the review of core public health programs, the focus and requirements also changed. As the slide demonstrates, the core public health programs became reframed as public health services, and then more recently as healthy families, BC, and key results areas. And last year, provincially, we had developed and established guiding framework for public health in BC, and then this year we're expecting a specific preventive health plan for implementation. So, of course, these priorities, even though they're reframed and transitioned from the core public health framework, they're linked closely together. And of course, the core framework could be viewed as foundational to some of those developments. However, as I mentioned previously, one of the realities that we often face in public health and otherwise is that we measure what's actually required to measure, and with the changing context, we are also faced with changing reporting requirements, which makes that whole system of health performance measurement and management quite a challenge. So with that, I would like to ask Jeannie to talk about science of performance measurement.
Thank you, Victoria. So I can advance this now. Should be able to advance this. Okay, so as we talk, this has been a great background for the understanding the complexity of the science of performance measurement. And a lot of times it goes through the types of indicators that we have to measure. That's one of the first questions that we ask after the conceptual framework that kind of tries to organize our thinking. An indicator is a qualitative, but usually a quantitative parameter that varies predictably as a function of how the component parts of the system are working together. So it needs to be precise in that it actually is sensitive to variations and changes in the system. And ideally, and this is difficult, it needs to be simple and understandable when we report on it. We often will talk about formal and informal measures, and in the formal measures, you've heard about the input or structures, process, and outcome framework, which is the most commonly used. This is also referred to as just the structures, the credence, and some of the reputational elements that we address. So the structures these are measured by the activities that can be done or the finance metrics, about how much resources are put into the system, what is in place, what kind of providers are available, and so on. And they tend to be relatively precise and simple to measure, but sometimes not so easy to link to the processes and outcomes. For technical skills, this is the processes part that we're usually interested in, about the actions that caregivers undertake that somehow reflect their competence and their skill level in providing the care. Another indicator of process is the user experience with care. So this is typically measured by things like accessibility of services, perceived quality, respect, and responsiveness, and is actually being recognized as increasingly important, I would say, in the last years. Finally, there's the health outcomes. They are actually usually the ultimate goal of the system, to reduce morbidity, mortality, and enhance health. And these measured by hard outcomes such as, death and prevalence of certain illnesses. And increasingly lately, there's been more emphasis on patient-reported outcome measures. That is, the extent to which patients feel that their function or quality of life has been improved as a result of care. So the different metrics that are fit into the conceptual models that were mentioned earlier are kind of taken together and to form a portrait of how the performance is in the system. Usually that portrait is quite partial. We don't actually have a complete portrait of how the system is functioning. And it can be at a very high level with little detail, or it can be sometimes at such a low level that we don't really know how the rest of this system is functioning on top of it. And we'll talk a little bit about that later in terms of the challenges. Measures of context are increasingly necessary to be able to understand those portraits. There's also informal measures, such as the reputation and trust that people have in the institutions, which can be actually quite rich and helpful, but they tend to lack consistency and comparability. So performance measurement is both a science and an art. It's a science in the sense that we can select good indicators, but those actually depend on how comprehensive or in-depth our knowledge is about system functioning and the causal links between the different components. And even with that understanding in our conceptual models, we need ongoing methodological development for being able to analyze, interpret, and represent the data in a way that actually makes sense. This is where visual analytics become increasingly important, because they are ways in which we actually take that huge complexity of the portrait or of the data and try to present it in a way that is intuitive to the users so that they can understand it. Performance measurement is an art in that there is a limit to science, and we often are having to make a judgment about use of indicators with imperfect knowledge. And sometimes even looking at the portrait that is done, we kind of have to squint to figure out exactly what it's saying. Just like in a museum, there's some portraits that look great from a distance, but then up close, you can't really tell what's going on. And I think that we also have to have a certain humility that is part of the art of performance measurement, by nuancing our judgment, by recognizing that we have limitations in the science and that the context can change what performance portrait is. We need to have ongoing discussion and collaboration as we move forward with those who are using the performance information, as well as with who is the best informed in the field to be able to just keep up with what the causal links are in the field. So some of the key ingredients around the science of performance measurements are having those good conceptual frameworks that everybody can agree on and buy into. Data availability and usability is a huge issue. Sometimes what is available is not the best measure, and having an imperfect measure can drive imperfect performance portraits. One of the issues, too, is actionability, and this is where we come down to a portrait that is granular and meaningful at the cold face where we can actually enact changes, or just something that makes sense from a very high level, from the 35,000-foot level. And then, of course, there's the ongoing search to understand the concept, the context, and ways that factors actually can affect performance, and to also recognize that priorities change from system to system and place to place, and we need to account for that. So some of the gaps and challenges in measurement, we've made a big point about having to expand the scope of performance measurement. We've already mentioned that much of the performance that exists in Canada is based on health administrative data that is very applicable to hospitals, but much less applicable to other sectors like primary care, community services, social services, and public health. And we really need to be developing measures for those areas. We also have very poor measures of integration about how the component parts of the system work together. Many of the new measures that we're developing are from patients or from new data sources such as electronic medical records, and that is just at the beginning of some of the science. We have concerns like efficiency, and I should mention equity in that sometimes are things that depend on secondary analysis of the data that we've got and require good measures as well. Probably one of the biggest challenges in performance measurement is the challenge of attribution. That is measuring, having indicators, just recognizing that our indicators for structures, process, and outcomes do not share the same time scale, and that outcomes are way often in the future and disconnected sometimes from the processes. And although outcomes reflect the ultimate goals, we do need to recognize that they're due to multiple influences, and that they can't always be attributed to providers or to the organization or even to the health system. And that's even true for certain processes. For instance, safety indicators don't only depend on the competence of providers, but also on the organization and how it is structured. So as we are moving forward in the evolution of performance measurement, we are, one of the things that we're looking for is having data sources that really reflect the system complexity and are comprehensive and actually take into account what matters to the different stakeholders in the system. We also look to replace proxy measures such as readmission rates to hospitals with real measures of clinical care provided in the hospital, as well as support services in the community. One of the challenges also is just the changing system priorities, that the health system changes faster than the knowledge that supports the causal links between changes. And we need to balance the measures that relate to the extrinsic motivation or accountability or the high level view with the intrinsic motivation that relates to continuous quality improvement at the coalface by providers. They're two different approaches, two different levels of granularity, and we need to somehow figure out how to combine those. And finally, there's the need for sophisticated analytic techniques that really take into account all the many confounding factors and contextual factors that need to be considered for providing valid portraits that are acceptable to the people who are using them and that they can actually enact them. And with that segue, I would like to move on to the next section, which is on reporting of performance measurement by Sabrina.
Great. Thanks a lot, Jeannie. Of course, in terms of the science, we absolutely have to improve that, and I think there's a lot of room to also improve on the reporting of the performance measurements. So panelists from the 2014 CHSPR conference suggested that in order to report on the performance of a system, data needs to be liberated and publicly reported on. As an example, the Bureau of Health Information in New South Wales was established to conduct ongoing and comprehensive assessments of performance of that particular state. And they also have the National Performance Health Authority, which also is mandated to be reporting across all states in Australia, things that we don't have here in Canada. So their mandate goes beyond monitoring of routine data and contemporary reforms to provide a sound and impartial assessment of performance of the state and the country's healthcare system. They strive for balanced and fair assessment that must encompass areas that are currently not the subject of explicit policies. And other examples, particularly from the UK, you see that they have the quality outcomes framework, and there's lots of reporting that also goes on with that. So a 2012 report completed by the Agency for Research in Healthcare Quality suggests that in a performance measurement framework that includes measuring, influencing, and improving quality, public reporting is categorized as a means of influencing quality by providing incentives for change. In their report, they actually focus on how public reporting of healthcare quality information may provide incentives for quality improvement that ultimately provide higher quality of care. And in part, this is part of the Closing the Quality Gap, Revisiting the State of the Science series, which examines the role of several interventions in promoting quality healthcare. So I think the reporting aspect of it is really useful. And what also that they found was that healthcare providers are more likely to engage in activities to improve quality when performance data are public. And this is from a big systematic review that they've done, and that in fact there's little to no harm in the public reporting. So this was something that has come up before about, well, it actually might be harmful because people don't know what the reports are about, et cetera. And in fact, what they found was that there is little to no harm in the public reporting. So that's the good news about public reporting, and that it could possibly be part of the catalyst of change. So from our CHSPR conference, another person that presented was Lena Cuthbertson, and she's the Provincial Director for Patient-Centered Performance Measurement and Improvement, and she's also the co-chair for the BC Patient-Reported Experience Measures Steering Committee. And these are some of the things that she told us about at the conference, was that providers were particularly wanting more timely data. They wanted to have more frequent reports for quicker access to results, that they were overwhelmed with the amount of data that were coming in. They didn't know how to read the information or take it all in. So the reporting really needs to be succinct and focused, and it needs to meet the needs of the providers or the audience that you're giving the reports to, and accountability, that they're easier to read, that reports give a snapshot of the patient's experiences, and they're relevant at a particular level. So, and we've heard this before, that, reporting at a sort of a province-wide level is pretty much irrelevant to people, but if you can try to decrease the unit by which you can report on, so that you're reporting either at a facility level or a small jurisdictional level, that actually then has meaning for the people that are delivering healthcare services. And so what they've done now is that they actually provide these monthly reports that have a combination, as Jeannie talked about, a little bit of a portrait, where they're giving some quantitative data and they're giving run charts with confidence intervals on different indicators and how they're doing. And then they also provide qualitative data that come from patients about some of the interpretation that might go on that you might see with the numerical data. And one of the things that we have really found is that you cannot report data that's acontextual. So the data must be contextualized for the target audience that you're reporting to. And finally, they also provide annotations to explain trends that are happening in the data and prompt the people who are looking at these data, and these would be the clinicians, at the point of care to reflect a little bit more on the data to see why might that be happening. So that's an example. And in order to improve public reporting, clearly there's challenges. Performance measurement, again, is demanding, and it's not easy to get the right audience or to get the reports so that they're reaching the right audience. So most members of the Canadian public, which is different from the U.S. context, will not need or use performance measurement reports to inform their choices about whether and where to seek care, because our system doesn't work that way. But performance measurement does get the attention of care providers and creates a mechanism for and commitment to translate it into concrete improvements. So whether this is at a practice level or at a different level, it absolutely can at least stimulate the conversation along as to what might be done differently. One of the things that we have challenges with is that there has been performance measurement coupled with funding. And the people at our conference really talked about how this needs to be decoupled, that there is a need to invest in performance-enhancing infrastructure so that information that support coordinated care, team-based care for those with complex needs, and rewarding organizations for good performance while penalizing those who are performing poorly only helps good organizations get better while depriving organizations needing improvement the resources they need to improve. So rewarding organizations, such as teams and units, also makes more sense than just rewarding individuals, as healthcare performance is most often a function of a team and environmental factors. And finally, there's characteristics of the intervention and context which are likely to be important when considering the diffusion of quality improvement activities, which have rarely been studied or described at this point. And so public reporting asks us to focus our attention on what is working, so that's the efficacy, but who does it also work for and in what situation? So we want to be paying attention to both efficacy and effectiveness. So going forward, we need to try to ensure, this is a question that was posed by Stephen Peckham from the UK, how do we ensure we measure what is truly important and not simply just things that we measure that then become important in that way. So what I'm going to do is I'm going to turn it over to Victoria Lee, and she's going to talk a little bit about moving forward and what's needed to move forward.
Thank you, Sabrina. So we've talked about complexities and some of the challenges in having an effective performance measurement system. And I think in terms of that requirement to have a successful measurement system, there's certainly a component that we need to facilitate a cultural shift that recognizes the importance of performance measurement. And as Sabrina mentioned, really to embed it in day-to-day organizational process and also in continued quality improvement processes as well. Another important element is capacity, and it was mentioned by both Jeannie and Sabrina and others at the conference that there's certainly a need for improving capacity and increasing our ability to do performance measurement within population public health as well as primary care and overall health systems. And often performance measurement is given us a task to do on the side of main roles and responsibilities, but we need to ensure that we actually have engagement at all levels from frontline to senior leadership, and to have dedicated capacity to devote to performance measurements. I think we often see that we are constrained by availability and accessibility of data, and we've talked about broader health system as well as community-based systems, and having linked database from population public health, primary health care, and acute services to other services, just pharmacy, all of that information and data, again, is critical to examining the system as a whole instead of parts of the system or individuals within the system, to ensure that we're looking at the overall attributes of performance in the system. And lastly, ensuring that there is that flexibility in implementation of performance measurement. As Sabrina just mentioned, often performance measurements are also tied to funding and resources. And again, there are challenges of ensuring that everybody has that infrastructure that's available for performance measurements and implementation. So having that flexibility and collection of data and reporting as we work through performance measurement in primary health care, population public health, I think is another area that's of importance in terms of building a strong performance measurement system. So with some of the challenges and looking at the requirements for a strong performance measurement system, I think there's also opportunities that I had discussed at the conference more from population public health perspective. And as you know, for some of you that are familiar with population public health, instead of stethoscopes for individual patients, in population public health, we have health assessment disease surveillance as the diagnostic arm. I think we have opportunities to contribute broadly to community systems as well as health system. For instance, within the health system logic model of CAIH's performance measurement framework that Sabrina reviewed, there are potential benefits of population public health information data that are noted across the health system in the inputs and characteristics, outputs, as well as outcomes, and of course in the area of social determinants of health. Specifically, there's areas such as adjustments within the health system to population health needs, health protection, health promotion, disease prevention, as well as overall outcome of the health system that we're interested in, which is improving health status. Furthermore, there are opportunities that exist to utilize accountability that's necessary within performance and as part of reporting. As an engagement strategy, and that could be done within the program organizationally across the health system, as well as our communities and funders potentially. So using that performance matrix as engagement and communication strategy. And I think related to that is that communication tool. At the conference, we saw some innovative and effective tools to communicate to the public as well as to engage stakeholders, from infograms to videos. And I think especially in the areas of complexity in health systems and where other sectors are also involved in health equity, non-communicable diseases, I think developing effective communication tools is another opportunity that certainly I see the role of population public health in, and also for primary health care and the broader health system as well. And with that, I'll ask Sabrina to talk about some of the policy implications.
Yeah, thanks a lot. So I think these are, they're here on the slide for you, and these are some of the things that we need that I think are things that policy makers can help us with. So helping us to build health information systems where there is interoperability and that data are linked. And in some places this is happening more than others, and there are performance measurements happening at different levels, right? So in practices, in health authorities, at the provincial level. And at different places this is happening, but it's not happening to a large extent where we see the linkage of the community and home services with public health, with primary care, all the way up through to acute care. So I think this is definitely something that came out of the conference. Another one that people talked about was that patients in particular need to have access to their data, and that this actually helps with some of the reporting on performance and can help us to improve the science of performance measurement. And we have examples where this has happened, mostly from the U.S., where they've done the patient portal. So Group Health, for instance, and also Kaiser Permanente. And so just another couple points is that the data, we need to have access to the data. So not only do we have to build the information systems, the data need to be liberated in such a way that they can be used for performance measurement. And we have to work hard to build the trust and rapport with providers and patients and stakeholders all the way up the line in order to be able to do this. And there has to be a willingness to be able to do this. And then finally, we have to continue to build our capacity to be able to report on performance and use the data. And I think we're in a nascent stage here in Canada in that area. So these are some of the key enablers. They're all, I could spend a whole bunch of time talking about that, but I'm not going to in the interest of trying to get to questions. And so I just wanted to let you know another step sort of moving forward is that we do have a team grant. All of us on the panel are on this team, and we're wanting to understand how to improve the science and reporting of primary care. We want to improve the science and reporting of performance in the area of community-based primary health care. And so what we're trying to do is to take areas that are similar, they're called peer group A regions that are specific clusters that apparently are similar in their sociodemographic characteristics. And this was some cluster analysis that was done by Statistics Canada. And there you can see they're across 3 different provinces. And our idea is that we would create these performance portraits that would include the quantitative measures and also the contextual data in order to create the portraits so that we can have discussions with providers as well as the stakeholders in those areas, policymakers in those areas, to see what we can talk about in terms of improving performance. And so we're learning a lot of things, as we've talked about, in terms of that, yes, you have to improve the science, and so we're improving the science by having survey data that will be linked to administrative data at this point. And, one of the questions was, what are the things that are most likely measured using with patients? And, those things would be access to care, continuity and coordination, interpersonal communication, comprehensiveness, and trust. Broadly, those are the domains. And then we're linking that to provider surveys, which are linked to practice surveys, which are then going to be linked to the administrative data. And here are some of the different sub-studies that are breaking down, and various ones of us are working on these studies. And so with that, I will end it, and I want to turn it back over to Jennifer for now answering some questions.
Thank you so much, Sabrina and Victoria and Jeannie. That was outstanding, and you've given us a good perspective on performance measurement in general, And Victoria, you've given some examples of performance measurement in BC and others. And Jeannie, talking about indicators and some of the challenges around that, and the examples of performance measurement frameworks. Really given a good overview, I think, for our participants. I do want to move quickly into questions and answers, and this is the time when participants can post in the chat box. Again, direct your questions to all participants. We do have a couple of questions in the queue, but please do post your questions there. And what I will do is simply read the questions at this point, and the appropriate speaker will ask you to help to address that question. And so the first question we have from Carol. I'm going to see if I can go back to the slide that I think you were referring to, Carol, in your question. So here we go. Carol asked, what about practitioners as a category under the for whom? So the who is it being measured for in the far right column for self-assessment and quality improvement. So we're just wondering if practitioners would be another category perhaps there. And Sabrina, perhaps you could comment?
Yeah, Carol, I absolutely agree with you. And I've actually added a box. So, yeah, providers for sure would be in there under who is it being measured for, because they would absolutely want to be interested in improving their own practice.
Sabrina. So we have another question. This one is for Jeannie. Could you please speak more about what types of indicators are often used to measure patient experience? Sorry, it's from Jeannie and perhaps Sabrina. Okay, to Jeannie.
Thank you very much for that question. In fact, probably the ones that are most classically used or originally were elements around patient satisfaction with their health care, and that was probably, and their responsiveness, the extent to which their privacy is respected, and so on. But I think that increasingly there's been more recognition of the areas in which patients really are the experts. So for instance, questions around accessibility we're recognizing that really it's the patient perspective more than just the utilization statistics that really give the correct picture of accessibility in the system, especially first contact accessibility. So a lot of there's a lot of questions also moving away from just general satisfaction questions, looking at the communication with professionals, the extent to which people feel also that their healthcare has activated them or provided them with skills that they need to look after their own care, how they experience coordination, if care is coordinated or uncoordinated, and aspects of quality. That, for instance, there's certain dimensions of quality like health promotion and certain preventive activities for which patients are actually a better source of data than even professionals, since they're the ones who actually have to carry out some of these actions. So that's an example of questions. There is a huge development in the area of actual questionnaires and questions to use, and I would say that the UK has been really at the advance of figuring out questions to ask in terms of patient experience, and that is one of the issues that we're trying to look at in the grant that Sabrina mentioned, because we would really like there to see a little bit more standardization in Canada about the questions that we ask. So we're trying to pull from all the different sources that we see people using and coming up with some suggestions about what might be some standard questions. I hope that answers the question.
Terrific. Thanks, Jeannie. Another question, perhaps Victoria or Sabrina might be best to answer this. How do evaluation measures fit in BC's performance measurement framework?
So Victoria, did you want to answer that question?
Sure, I can start, and I noticed that I was on mute. So so I think in terms of that evaluation, it goes back to one of the slides that went through the overall process of performance measurement. It's included as part of the core, it was included as part of core functions framework, so coming up with the concepts, objectives, best practices, indicators, and then evaluation as we benchmark to indicators, and the performance targets are embedded as continuing quality improvement, as well as performance measurement and reporting. And in terms of in practice, I think that's also a component that we're very interested in with the grant that Sabrina mentioned as well in community-based primary care system. I think one of the areas that we will be looking at within that performance measurement is that component of evaluation of how well we're doing. And I think those are naturally linked together. Sabrina, did you have any additions?
No, I don't. No. I think that was good.
Okay, we'll move along to another question, and Sabrina, it relates to one of your slides. Let me just go through it here. And the question is, when you're referring to the term context, and so rather than the formal 3 items in the CIHI model, what kinds of things are included? So if you can just elaborate on this a little bit in terms of what contextual factors are and what that means.
Yeah, so I mean, really good question, Martha, and I think this just really highlights the importance of having a conceptual framework. I mean, clearly these are very broad categories, and the context is going to depend on at what level you're doing the measurement. So if it's a practice, your context is going to be perhaps different. It would be maybe the practice context or even just that community versus if you were doing performance measurement, say at a health authority level, where you would have a different context. And as I've just finished doing some work looking at a comparative policy analysis, trying to understand some of the contextual factors that might influence the uptake of interprofessional care across 3 different provinces, and it's not an easy question to answer, and I think that's something that we're working through now as we think about this particular grant and how do we actually measure context. And again, this is something I think we also, depending on the unit of analysis, that you want to try to get some standardization across. So I do think, you know, there is going to be, it's different context depending on what it is you're looking at. So for sure, geographic context, whether, you know, what the breakdown looks like. I mean, there's a whole bunch of different measures that might be important to different stakeholders. So it could be the driving time to the primary care office, transportation. You know, so there's a whole bunch of different things. And at the practice level, the context could be looking at the funding, how it's funded, how the in particular the physicians are funded. It could also be the number of FTEs and whether or not there's an interprofessional team, etc. I hope that helps to answer the question. And I don't know, Jeannie or Victoria, if you have anything to add.
It's Victoria. I think you've outlined the various contextual factors really well. I think, as Sabrina mentioned, it really depends on the level of or scale of that performance measurement that you're interested in, from, I guess, the practice level to, it could be national organizational systems level. And as I mentioned, in terms of the political context, it has significant impacts in population public health measures, of course, in terms of required reporting from health authority or from programs. But I think in terms of if we're looking at the reporting and engagement of our stakeholders in the public as well as practitioners, there's also that cultural context, acceptability, and how information is packaged and reported that also impacts our performance measurement framework as well. So, for example, there's ethnic, cultural diversity within our region and where I work in Fraser Health, where across the 22 communities, we see a very different makeup of the population, and acceptability and availability and also understanding of reporting in those contexts would differ depending on where we're actually working. So I think it has multiple layers and has that scale that's important to consider as well, and overall, I guess, intent of that performance measurement.
Okay, excellent, thank you. We have a question here as well. Someone wondering where they can get more information about the 3 proposed conceptual frameworks, in particular the functional models. So I think that might be referring to, Jeannie, some of the stuff that you were presenting. I'm not sure.
I think it was actually Sabrina who was talking about the conceptual frameworks and comparing logic models with functional models and sort of like the goals framework. And I'm not sure if that fits so much as I guess Sabrina, you'll correct me, but I think that the intent when it was being presented was not so much to show necessarily a conceptual model, but it actually dovetailed with the slide that was shown about for whom are we reporting. And so sometimes there is reporting that is really related to checking the efficacy of certain functions in the system, as opposed to you know, a goal achievement or just trying to understand the logical flow. So I think that was the slide was originally presented in that sense. But I do think that probably functional models can also refer to a nuanced understanding of how a system functions and the causal links between the different elements, which is slightly different from a logical model, but it's really a much more nuanced understanding of how the actual functions come together within a complexity framework. Sabrina, I don't know if you wanted to also respond to that.
Yeah, no, I think that was a good response. We could perhaps give you some references. We have not done a literature review on all the different kinds of performance measurement frameworks and models, but certainly happy to provide you with some of the references that we have.
Okay, and maybe as part of the follow-up from this webinar, we can send out any of those resources along with the slides. And just would encourage, too, any of the participants on the webinar, if there's particular resources, links, other pieces related to performance measurement that others on the call can benefit from, please do go ahead and post those. We can collect them and then make them available as well. So another question, what conceptual model is more effective to link and identify performance metrics back to the factors that influence these metrics? How does the complexity of the factors, example, determinants of health, get processed into performance metrics? Not sure who would like to take that one.
I guess I don't think I can answer that question in terms of which conceptual model is best, but I did want to say that most conceptual models do recognize the fact that the outcomes at the end come from multiple factors, and in fact, most of the literature shows that most of the outcomes in the social sectors like education, social services, and health are affected by the initial characteristics or the initial components that individuals have in terms of material, psychological, cultural, and social background. So they are very complex, and one of the ways I know that in logic models often they are identified or at least in the one that we worked on the most, was just simply at the outcome, there was just an indicator linking it once again back to context, so that after you do your whole logic model, then there's this big arrow that comes in off the side to the outcome, linking it back to the social context that is actually one of the first things that determine what the inputs to the system are in the first place. That's just one example, but there's many, many social models, social conceptual models, and I think that one of the difficulties in the science of performance measurement is the chaos around the conceptual models and not just the chaos around the indicators, and that sometimes there is not agreement between the conceptual models. Sabrina?
Yeah, no, I definitely would agree with that, and I think it is fairly complex, and you need to have, first of all, if you were to test the conceptual model, you would need a large N to be able to, a large sample size to be able to do that, and you would need to use sophisticated analytic techniques in order to try to capture some of the things that might be considered outcomes, but also could be considered inputs. And so it would, yeah, it's a complex question that you're asking, and certainly there's things that we don't measure in the context, particularly around some of the different social determinants of health when we're looking at performance measurement. And again, I think it goes back to both Victoria and Jeannie's comments that at the end of the day, we're getting a small slice of a portrait, and we're often missing a lot of information, and we can only do what we can do. And, you know, in terms of trying to improve the information system that's available, and then also the science and all the reporting.
Thank you. Another question here, perhaps for Jeannie. How would you distinguish between patient satisfaction and patient experience?
So patient satisfaction requires patients essentially to judge, to pose a judgment about the extent to which the services that they received met their expectations, which what typically goes unmeasured is the measure of those expectations. And it also, I think that there's research showing that patients feel, it actually puts them in a position to make a judgment about people that they're dependent on, and they tend to be very, like when they say something is unsatisfactory, that's almost certainly true, but when they say something is satisfactory, there's a lot of social desirability related to that because they really are in a dependent position. So moving towards patient experience is just simply asking patients to just report on what happened. How long did you wait for your appointment? Were you treated with respect? Were you given enough privacy in the room that you held? Did you understand everything that your provider said to you? Those things. And then it really is up to people measuring to come up with a judgment whether that's acceptable or not. So it's much easier to pose benchmarks and to be comparable between regions or between people who are being compared, because it's not contaminated, if you like, by the differences in underlying expectations that patients have.
Thanks, Jeannie. That's all the questions we have in the queue at the moment, but while we're waiting for any final questions from folks, perhaps I could just ask each of you just to spend perhaps a minute just with any reflections, words of advice for the participants as we start to wind down. Jeannie, did you want to go first?
I'm sorry, I was just in the process of reading a very interesting question, which was that I'm trying to look for it at the end, but it was about what we believe the immediate next steps to achieve national improvement through measurement. And certainly, I think that one of the things that we're confronted with is the extent to which we have these jurisdictional boundaries that it's hard to compare across jurisdictional boundaries with our richest source of data, which is health administrative data. So I think that just being able to increase the sharing and cross-jurisdictional collaboration would be a huge benefit. And then, you know, it does feel like we keep talking about liberating data that would allow us to link data from different levels as well. So I think that that's really one of the most important immediate next steps, and related to that is the electronic medical record.
Yeah, I would agree with that, that we do need to have the clinical data come from a credible source, and that is the electronic medical record. And along with being able to liberate the data comes, you know, more, we need to be confident in the data. So the clinical EMR data at this point are quite, they're not as rigorous, they're not as clean, I guess, as you would expect. And that is because there's different operating systems across the country. And then along with also liberating the data, we also need to figure out the privacy issues, and we need to really interpret the legislation in a way that we have a common understanding of how we can use that data in a way that respects the confidentiality and privacy laws, but that we're able to use it and not be fearful of using it. Victoria, do you have anything to share on that particular question?
Sure, I certainly agree with what Jeannie and Sabrina mentioned. I think that data, information, access, and availability, and having that linked data across different services and systems, as well as across jurisdictions, is an important next step. I think the other thing I'd like to mention is really that capacity building and infrastructure that's necessary to have a robust performance measurement system. I guess in terms of looking at population public health programs, I think, as I mentioned, we see data surveillance as an important critical part of what we do day to day. But linking it to performance measurement, I think there still needs to be quite a bit of capacity building, ensuring that we actually have standards of competencies outlined in that area, and training, education available, as well as linking it to organizational performance and that engagement of leadership and commitment to deliver on performance measurement.
Thank you very much. I think that was a great question to kind of wrap things up. But are there any final concluding remarks or thoughts that any of you want to share with the participants at this point?
This is Jeannie. I would just like to say that when we, at our conference, we were sort of jealous of our Canadian colleagues who are in Australia, and when they produce reports, they get huge media coverage on their performance reports, because there really is an appetite in the public and also by the different organizations and providers to know how they're doing. And I would love to see that culture also happening in Canada.
Yeah, this is Sabrina, and I just would say, you know, for a publicly funded system, the accountability lies with being able to report back to our taxpayers the value of their system. So I think, you know, we have to all sort of try to get on the same page and, you know, be able to report in a way to the public. So I think that's one thing, and I think that's going to take a lot of engagement with patients and the public in order to help us to get there, because I think if you can build a system that is by patients, for patients, that is actually going to help serve us better, and that we have to remember who our service users are, if you will. And then finally, I think we need to be able to report at a level of actionability, so that reporting at a provincial level even though we could get cross-jurisdictional learnings across, that we have to be able to also be reporting at smaller levels where people can feel like this is meaningful to them, both patients but also the providers and the policymakers in those areas.
Victoria, anything to add?
No, I think the only thing I would emphasize is that communication part. Again, I mentioned it during going through the slides, but I think, you know, in terms of overall system performance in population public health world as well as otherwise, how do we actually effectively communicate and engage our stakeholders? And as Sabrina mentioned, we're looking at patients, communities. How do we engage them in ensuring that we're communicating how well we're doing? And I think that's an area certainly that's worthwhile for us to look for innovative methodologies.
Excellent. I'm just looking at the chat box here. I don't see any further questions at this time. I would encourage all of the participants, if they do have questions, I can post here the email addresses for all of the speakers. And again, this will be submitted or provided to you after the session on our website. So you can contact anyone here for any additional information or if you have questions still outstanding. I do want to thank the three speakers, Victoria, Sabrina, and Jeannie, for an excellent overview of this issue and some key thoughts on next steps that I think has been very valuable. I want to thank everyone on the line for participating here today. And as I mentioned, this is part of a series of webinars that we have. We aim to hold one every month. And so your feedback is very important to us as we host these and aim to deliver the best possible webinars for you. So if there's topics or any suggestions on how these webinars are done, please forward them. And you will see after the webinar a feedback form, so a poll that will pop up on your screen. Please do take a few minutes to complete this, and your feedback does indeed matter. So with that, I'll conclude today's session and thank everyone again, and especially the speakers, and wish you all a wonderful day.
Thanks very much, Jeannie and Victoria, and the rest of the CIHR team, and also the participants. That was really interesting. Thank you.
Thank you.
Thanks, everyone.